So hey guys, hello and welcome to my YouTube channel. I hope that you are doing absolutely fine, and in this video we are going to talk about anemias. So if I talk about anemias from the USMLE's perspective, I want to reiterate this fact that anemias is a very important topic when it comes to USMLE step 1 exam and step 2 exam. So I would say that you should pay a great attention to this topic, as you can expect I would say maybe like 5 to 6 questions on the real deal. So, from the USMLE perspective, what is anemias? See, guys, anemia is a condition where the RBC that are circulating in your blood, they are relatively low. And how do we know that the RBCs they are actually low? There are two metrics to find out. One is the hematocrit, and other is obviously the hemoglobin. And in your exam, they will be revolving. The questions will be revolving around the hemoglobin. They will be telling you that the hemoglobin is less than 13.5 and or the hemoglobin is less than 12.5. So whenever there is a scenario where the hemoglobin is less than 13.5 in case of males and the hemoglobin is less than 12.5 in case of females, then you say that this is a case of anemia. Now the question doesn't end over here. You have to find out which sort of anemia is this, whether this is a iron deficiency anemia, or this is a folic acid deficiency anemia, or this is just a hemolytic anemia. So you should be able to understand how to approach once you have made a working diagnosis of anemia. So once you have made a working diagnosis of anemia, let's say, this is a case of anemia, now how to proceed? So I would say the first step that comes in the picture when you have a working diagnosis of anemia is to find out what is called as the MCV. Now let's go ahead and try to find out what is this MCV and what do you do with this MCV in the real exam. So MCV is like a parameter, is like a parameter which will give you an estimate regarding the size of the RBC, like what is the size of the RBC. Okay, so so MCV, normally the size of RBC or the normal MCV is between 80 to 100, and in case the MCV is less than 80, the cells are like little smaller than the normal and they are called as microcytes. In case the MCV is between 80 to 100, the cells are exactly the normal size and they are called as normocytes. And in case the MCV is more than 100, the cells are little larger and they are called as macrocytes. Now, so the cells are of three types. We can have microcytes, we can have normocytes, and we can have macrocytes depending upon the size of the RBC. Now, let's say a patient has anemia, that is the hemoglobin is less than 13.5, and you see MCV, and MCV can be either of these three. It can be this, it can be this, it can be this. Okay, so now on this basis, anemias can be of three types, and this is the most important point. The anemias can be microcytic anemia if the MCV is less than 80. Anemia can be normocytic anemia if the MCV is between 80 to 100, and anemia can be macrocytic anemia if the MCV is more than 100. So this is the thing where you start in the real exam. Okay, you have a patient who has anemia, you calculate the MCV comes between less than 80, you say that this is a case of microcytic anemia. MCV is between 80 to 100, you say this is a normocytic anemia. MCV is more than 100, you say this is a macrocytic anemia. Now, the next question is, how do we divide, or I would say, how do we dive deep into microcytic anemia? How do we dive deep into normocytic anemia? And how do we dive deep into macrocytic anemia? So let's start with the microcytic anemias first. Okay, so I have the microcytic anemias, right? So the microcytic anemias are those in which the MCV is less than 80, right? So MCV is less than 80. Now let's dive into the pathophysiology of microcytic anemia, like how the microcytic anemias they arise. So let's say this is a normal RBC. Okay, it is a biconcave shape RBC. Sorry for my bad handwriting. And you know that within the RBC we have nothing but we have the hemoglobin, right? So this is, let's say this is the hemoglobin that is distributed among the RBC. And let's say this is a normocytic RBC, which means that the size is absolutely normal. So this is a normocytic RBC. Now, what happens in case of microcytic anemias is that the hemoglobin production is decreased. Okay, so the hemoglobin production is decreased, and now as a result of the decreased hemoglobin, I would say the cell, it undergoes an extra division so as to distribute this hemoglobin quite fairly. So now you will have these two RBCs. They will be of smaller size, but they will have a fair distribution of hemoglobin, and that is the idea, or that is the manifesto behind the microcytic anemia. So to wrap it up, anything that decreases hemoglobin will cause division of RBC, and this will cause something that are called as microcytes. And because the hemoglobin is being decreased, so therefore there is anemia, right? So now you know why there is microcytic anemia, because of decreased production of hemoglobin and the RBC undergoing an extra division, right? So now the question arises, like, why is there decreased hemoglobin? And that will take you to the causes of microcytic anemia, right? So to understand this, let's try to understand what is hemoglobin composed of. So the hemoglobin is composed of two things. One is heme and one is globin. So globin is nothing but it is the protein part, right? So globin is actually the protein, and heme, it actually consists of two things. One is the iron that is in plus two form, and the other is protoporphyrin, right? So the protoporphyrin is all those ringed structures that you used to study in your biochem lectures in the first year of med school. So the heme, it consists of two. One is the protoporphyrin, the other is the iron, and the globin is nothing but it is the protein part, right? Now, the hemoglobin can be less if any of these components is less. Let's say there is a less globin. So if there is a less globin, obviously there is less hemoglobin, and there will be something called as microcytic anemia. Now the question arises, like, where do we find less globin or less protein? So obviously in conditions such as thalassemias, we find this less globin, and as a result of this, there is microcytic anemia. Now, thalassemias can be further of two types. There can be alpha thalassemia if the alpha globin chain is less. So beta thalassemias can be, in the situation where the beta globin is less. Iron is less in something which is called as iron deficiency anemia, and protoporphyrin is less in case of two, three situations. There can be sideroblastic anemia, which is nothing but, a condition where there is decreased protoporphyrin, or it can be less in case of lead poisoning, right? So, or it can be less in other situations which we don't need to dive deep into. Okay, so these are the four main causes of, I would say, the microcytic anemia. Okay, so the four main causes of microcytic anemias are iron deficiency anemia, which is obviously the most common type of anemia overall. The other one is the thalassemia. Okay, so in case of thalassemia, again, you have the microcytic anemia. Then you have the sideroblastic anemia. And last but not the least, you have miscellaneous things like lead poisoning. This also causes microcytic anemia. Now we will be diving deep into each one of these, like iron deficiency anemia, thalassemia, sideroblastic anemia, and lead poisoning one by one. But now in this video, I'm gonna take you through the overall classification of the anemias, right? So that you understand the basic concepts, and you never forget these concepts, because understanding iron deficiency anemia, thalassemia, sideroblastic anemia is like relatively easy when you have a basic understanding of what is going on, right? So let's dive into the next major subtype of anemias, which is the macrocytic anemia, right? Okay, so if we talk about macrocytic anemia, as the name suggests, like macrocytes, in case of macrocytic anemia, the size of the RBC is like big, so the MCV is more than 100 in case of macrocytic anemia, right? Now, let's try to understand what is the pathophysiology. So, let's say this is an RBC. This is a RBC which is undergoing the maturation and the division in the bone marrow. So what happens in the bone marrow is, like, you have a bigger RBC that divides into two smaller ones. This may not be smaller, but just an example. And this smaller RBC will divide further into two smaller RBCs, and this RBC will again divide into two smaller RBCs, and these RBCs, they will just enter the peripheral blood film or the peripheral blood stream, right? So what happens is that this nucleus is being split it into two, or I can say that two nuclei are being formed, and from these two nuclei, the four nuclei are being formed, and this is the whole scenario that is occurring within the bone marrow. Now, always remember these cells they are called as blasts, right? These cells they are called as blasts. These immature cells they are called as blasts, right? Now you can understand or you can think that in order to make this division possible you need to make these DNA RNA, right? So only if you make these DNA RNA, these RBCs they are gonna divide, and then these RBCs they are gonna further divide, right? So now let's imagine a situation. If you imagine a situation where you cannot make this DNA and RNA, so you will not be able to divide these RBCs. So consequently, if let's say from this RBC, let's say 10 or 20 RBCs were being formed by the division. Now this is not happening. So what will happen is that the overall number of RBC will be less, right? So the overall number of RBC in the bone marrow will be less, and the number of RBC in the peripheral blood will also be less. So you know that the less number of RBC is nothing but it is the anemia, right? So as a result of this there will be anemia because the number of RBC is less. Now, why do I say that this will be a macrocytic anemia? I say that this is a macrocytic anemia because these RBCs, those are large RBCs, they will just go into the peripheral blood film as the larger RBCs, right? There will not be any division, so they will not be gonna becoming normal size RBC. They will just go as like these big giant RBCs, and that is why it is called as macrocytic anemia. So now you have an understanding of what is macrocytic anemia and why does this arise, right? So macrocytic anemia in most of the cases will arise because of either B12 deficiency or folate deficiency, because either in case of B12 deficiency or in case of folate deficiency you will not be able to synthesize the DNA RNA, as a result of which there will be no division of the RBC, and since there is no division of the RBC occurring, so there will be less number of RBCs, and the RBCs which are there, they will be of larger size, they will be of increased size, or they will be of larger size. So this is all what is happening in case of the macrocytic anemia. Now there is another thing that I want to add over here is that these macrocytes, that is the big RBC that you see in the peripheral blood film, right? In the peripheral blood. But in case of the bone marrow, if you look into the bone marrow, you will find something called as megaloblast. Now, I already told you that the cells in the bone marrow, they are blasts. And since those cells, they are like large cells, they are called as megaloblast. So they are called as megaloblast. So this is what is happening in case of the macrocytic anemia. So B12 deficiency and folate deficiency are the two causes of the macrocytic anemia. Now I will go deep into how B12 deficiency is occurring, how folate deficiency is occurring, but this is just an overview, right? So I will go into that slide where I talked about the causes of microcytic anemias, right? These were the causes of microcytic anemia. Now here we have the macrocytic anemia, and the predominant causes of macrocytic anemias are either the folate deficiency and the B12 deficiency, right? So these are the major causes of macrocytic anemia, and these are the causes of actually the macrocytic megaloblastic anemia, right? So the macrocytic megaloblastic anemia, these are the causes of macrocytic megaloblastic anemia, right? Let's dive into something called as normocytic anemias, and where we will be discussing about non-hemolytic and hemolytic anemias. So let's dive deep into that. As I already told you that in case of normocytic anemias, the MCV is between 80 to 100. That is, the cells they are absolutely normal. Now we say that the normocytic anemias, they may arise because of two reasons. Okay, either there is a decreased production of the RBCs, or there is the increased destruction of the existing RBCs. Okay, so either there can be decreased production of RBCs or there can be increased destruction of existing RBCs, right? So there can be increased destruction of existing RBCs. Okay, now, there is an important thing that is helpful in differentiating the causes of normocytic anemias, that is the reticulocyte count. Okay, now what is reticulocyte count? Now, actually, what happens is that the reticulocytes are actually the immature RBCs which are being produced by the bone marrow and they are being thrown into the blood. So, what happens is that if the bone marrow is functioning properly, and you get an increased destruction of RBC in the peripheral blood, the bone marrow will be, kind of trying to compensate for those destruction, and it will increase the, reticulocytes that are being thrown into the blood. Does it make sense, right? So, as a result of that, in these kind of anemias where there is an increased destruction of the RBCs, the reticulocyte count will be increased, and actually it will be more than 3%. So these kind of, anemias in which there is occurring a destruction are called as hemolytic anemia. And how do you differentiate hemolytic anemia? Is that in case of hemolytic anemia, the reticulocyte count will be increased, and in fact it will be more than 3%. Now, whereas in the other extreme, that is, there is a decreased production of RBCs. Obviously, since there is decreased production of RBCs, if you kind of try to do it retrospectively, you can understand that the problem is within the bone marrow, and obviously since the problem is within the bone marrow, the reticulocytes will be low and reticulocytes count will be actually less than 2%. So this is how you differentiate these non-hemolytic anemias from hemolytic anemias, right? So now let's come to the original picture again, and let's try to find out how do we talk about normocytic anemia. So in case of normocytic anemias, the first thing is that the MCV will be between 80 to 100. So if you find a case of anemia where the MCV is between 80 to 100, you know that this is a case of normocytic anemia. Your next bet would be to find out reticulocyte count. If the reticulocyte count is increased, you say that this is a case of hemolytic anemia. And if the reticulocyte count is decreased, you say that this is a case of non-hemolytic anemia. Now, the hemolytic anemias, they can be of two types. Either it can be extravascular hemolysis, okay, either it can be extravascular hemolysis or it can be intravascular hemolysis. Now, what is this extravascular hemolysis and what is this intravascular hemolysis? I will be just coming down to it. And non-hemolytic anemias are just where there is decreased reticulocyte count. Now, what happens in case of extravascular hemolysis is that the RBCs, they are being destroyed or they are being hemolyzed, but this happens in the reticuloendothelial system, which is like a specialized system consisting of macrophages present in the spleen, in the liver, and things like that. So spleen, liver, etc. Now, what are the examples where there is occurring the extravascular hemolysis? For example, sickle cell disease. For example, hereditary spherocytosis. For example, in some sort of autoimmune hemolytic anemia. And in case of intravascular hemolysis, the RBCs, they just don't go into the blood, into the reticuloendothelial system. They just, are being destroyed within the blood vessels themselves. So that is called as intravascular hemolysis. And the classical examples where the intravascular hemolysis is occurring includes, I would say, G6PD deficiency. I would say pyruvate, not pyruvate kinase. I would say malaria. I would say micro or macro angiopathic hemolytic anemia. So these are the types, or these are the examples where there is occurring the intravascular hemolysis. So we have the extravascular hemolysis and we have the intravascular hemolysis. And last but not the least, we have non-hemolytic anemias. So these primarily arise because of the bone marrow depression. So this bone marrow depression may be because of certain things, and it may be because of drugs, it may be because of radiation, it may be because of some viral infection, or it may be because of some genetic disorder. All of these actually, they will cause something called as aplastic anemia, where there will be just no cell within the marrow, there will be aplasia, and in the peripheral blood will find low RBCs. So this is how, in the real exam, we're gonna go, with the microcytic anemias, with the normocytic anemias, with the macrocytic anemias, and this is how, the real classification look like. So in this slide, we had the causes of microcytic, we had the causes of macrocytic. So let's add normocytic. Okay, so normocytic, if the reticulocyte count is more than 3, this is a case of hemolytic anemia, right? So hemolytic can be extravascular hemolytic, intravascular hemolysis, different subtypes and different examples, like extravascular hemolysis in case of hereditary spherocytosis, sickle cell disease, some sort of autoimmune hemolytic anemia, intravascular hemolysis in case of G6PD deficiency, infections such as malaria, and microangiopathic or macroangiopathic hemolytic anemia. If if the if the reticulocyte count is less than 3, then it is non-hemolytic anemia, which may be seen in cases such as bone marrow depression, such as aplastic anemia, and things like that. So this was a whole, I would say, a real quick classification about how we approach anemias and how do we go behind the anemias in the real deal. So in the subsequent videos, I'll be taking one by one, the microcytic anemias, the macrocytic anemias, and the normocytic anemias. So till then, I hope that you understand this video well, and you study well, and you do really great in your real deal. So thank you so much for watching this video. If you like this video and you like the content that I am making, so kindly support me by subscribing to my YouTube channel. Yeah, till then, all the best and study well.